If you're good with it, oh, if you're good with it, we could do they're kind of like, well, not kind of, they're just MCRIT like podcasts that I was a big fan of. So I figured I'd type them up. I typed my own notes to kind of avoid just like a verbatim, kind of plagiarizing, stealing their ideas situation. And then I went on the New England Journal of Medicine and looked at this trial regarding oxygenation for pretty much anybody who looks like they're having an MI. This is dealing with only the ones that aren't hypoxic at baseline, because it's very common just to give oxygen anytime someone's having chest pain. And I had kind of briefly saw something on it that it was bad to do, and so I figured I should go and look it up. I actually really liked the article. And then I kind of just have 5 general questions, and I'm sure we'll branch into more
Sweet,
kind of as it goes. But you good with that flow?
Yeah, that's perfect.
Today, sweet. So the first one is kind of the bulk of the trauma. The second one was pretty self-explanatory, but will you let me know? So I've had COVID, so I didn't have time to print the notes off like in the binder that I usually have. So will you let me know if I come off the screen, because I'm going to pull up the Word document?
Yeah, for sure.
Okay.
I think it should. Yeah, I think your video will stay up unless I like hit the screen share, or one of us hits the screen share button.
Okay, you can still see me?
Yeah.
All right, so this one was kind of about the resuscitation of just your classic hemorrhaging patient. The kind of case that they used was a penetrating gunshot wound, but it was an 18-year-old, and the guest speaker was Richard Dudden, which I guess is a bigwig trauma anesthesiologist in shock trauma. Just really good points I kind of wanted to get your opinion about and everything. So kind of the clinical case was just the 18-year-old male shot in the right chest once, upper right quadrant once, loss of consciousness in the field, regained consciousness after a liter of crystalloids, blood pressure is 110/70, heart rate 130, pale and lethargic. So he kind of just starts with saying he's going to hang blood on this guy right away, kind of regardless of how he looks. Throughout it, he really harped on the fact that he is an 18-year-old male and he can handle deep shock very well in comparison with your older patients, or even somebody kind of in their 40s or 50s. He says, so this guy, he said he could lose up to half of his blood and still, vital signs wise, look like he's doing okay. But once this patient crashes with that much blood loss, it's going to be real sudden, real quick. So he kind of goes over the specifics of kind of how he would manage it, and bigwig doctor stuff, kind of how he would let the flow of it happen. The kind of key thing that I got from this is he talks about induction agents. And he says that the specific agent does not matter, which was new to me because I've always heard etomidate is a really hemodynamically stable induction agent, along with like ketamine. He goes on to say that once you're in deep hemorrhagic shock, regardless of if you're compensating or not, you get these changes in the brain. And he did not go into specifics, but basically stating that hemorrhagic shock itself is rather anesthetic itself. And so saying that he reduces his dose dramatically in these patients. For example, he was saying that usually he would give 200 milligrams of propofol, said that he would drop it down to 20 in this patient. And he says that he cannot find, at least at the time of this recording, I believe this is from 2013 or maybe even 2011. So it's been almost, or at least over a decade since this came out. But at the time, he was saying there was no research at that time regarding on this subject. And this is something that he found as a bit of empirical evidence through his practice. I thought that was pretty interesting, especially in these crashing patients already, because so many of these induction agents, I would imagine even etomidate and ketamine can drop the patient's pressure even further if they're already going down. So I kind of wanted to get your thoughts on that first piece about the reduction of dose in the induction agents.
Yeah, so I think that's a fair generalization that any of these agents could potentially like cause your blood pressure to drop, to cause that cardiovascular collapse. And there's two kind of thought process about that. One is that like some of the agents, like it's like a direct effect, like it causes your blood pressure to drop through like vasodilation, or some other effect along those lines. And the other thought is that in some cases, your body is like maintaining its blood pressure through its like endogenous release of catecholamines. And if you give a large dose of a sedative or an analgesic, you're taking that away. But regardless, whichever mechanism we're working with, like all these agents do have the potential to cause a drop in blood pressure and potentially lead to cardiac arrest. That said, the specifics about like attenuated doses in RSI, I think since 2013, there's been a fair amount of discussion about that. That said, I don't know off the top of my head any specific papers that looked into that about like how much to attenuate your dose, like if you're cutting it in half or doing a quarter. But I know in general that there is more of a movement towards that, particularly in cases like this where you have like a severe traumatic shock, like a hemorrhagic shock state, but also with elderly patients in general, just across the board. But I'll have to dig and see if there's any like specific recommendations about like, I don't know when to make that, like maybe like if your shock index is a certain amount, you attenuate it by half, and if it's this much, you could quarter dose. That, like I don't know about the specific guidance. I just know there's a lot of discussion. But that said, I'm not aware of any like specific guidance on that, but it totally makes sense. I do think I wasn't at the conference, but I think I can't remember the name of the conference. There's like a big flight medicine conference every year. I wanted to say it was ASNA, but that's not who it is. But they had a discussion and a talk and like follow-up discussions about this like right before COVID. So it must have been like 2019 or so. And I remember I had a friend or two reach out to me about that specifically to like see like, hey, what are you guys doing where you work? I'll see if I can pull up a recording of that or reach out to my buddies who mentioned that to me. But
yeah,
I guess there's a long way of saying that like it totally makes sense and it checks out. I just don't know like specific guidance. Yeah, I mean, where I work, we don't have specific protocols on that. Like we don't have like direct guidance on like how much to attenuate a dose. But in general, like if your dose says you can give up to like X amount of whatever medication, you can always give less, right? So that always falls under your discretion as a provider. So yeah, even though it's not explicitly written out, we would have the autonomy to attenuate a dose.
Yeah. Well, and I figured if you get to the point of being a flight medic, I mean, you have enough clinical experience to where your judgment should be, respected. It's not like you're a new medic coming off the street.
Right. I mean, that's the idea, I guess. Yeah. The other thing that we've been pushing a lot, like in the industry in general, is like before we give any medications to facilitate intubation, taking the time to resuscitate our patients. So we used to run into the problem where we would just, give full strength medications to these patients who are already in shock state and we kill them. And then it was like, well, maybe we can give like smaller doses. And then now I think the current process as well, why don't we like resuscitate first? And I think there's a middle ground, right? Like we likely could resuscitate and give smaller doses, but we're still in the process of ironing out the details of that.
Yeah. And it seems like it would be a rather difficult thing if for really anybody with experience, because it seems like medicine has come from get them intubated very quickly to now we have a little bit more time with things.
Yeah, for sure. I think that in the hospital setting, this idea of like a delayed sequence intubation has started to catch on. Maybe other flight programs are doing that as well, or other like ground programs. Not so much out here, but I think that's where it's headed in the future. We did talk about last time, there are situations where like you need to move quickly. Like in this situation, if this were like you or I looking after this particular patient in the field, that's a case where we do need to move quickly. But that's like in the direction of the hospital, not necessarily like move quickly, like giving him medications that could compromise his like hemodynamic status. So yeah, I think that's a little bit of a paradigm shift for just EMS in general. And then particularly in like the flight scene where we're often limited in what we can do in transport, just because like we work in a tiny little flying tin helicopter. We have a tendency to want to do these things in a more controlled setting on the ground. And if we're like looking to resuscitate a patient adequately, it could take a while. And then we've like delayed care, like, 20, 30, 40 minutes. Yeah, and there's argument that like maybe we just avoid the medications and you do like you just go straight to a crike, or you drop a supraglottic, or you know yeah, or use just BLS airway maneuvers. But I don't know, these are all good questions that hopefully the industry will figure out one of these days.
Yeah, it would be very nice if they did.
Yeah. Well, it's good to know that they don't have it all figured out. That means we still have things to look forward to and to learn about.
Yes. I like it when new information comes out, like the research that we're going to talk about a little later. I was very stoked about it.
Yeah.
Why I was stoked about it, I don't much know, but you and I were having a conversation earlier about the oxygenation just being a very fascinating topic. I just like it. There's just something about it. That and like pulmonary, sure. I don't know anything really with the right ventricle, and anything where somebody's dying because of the right ventricle. Like regardless, you probably don't wish it for people, but it is very fascinating.
Yeah, I guess it is a weird thing to have something for, but I mean, everyone's got their thing.
Yeah. Well, it's better not liking it at all,
Yeah, true.
So they kind of move on with the induction agents, and he was even saying he's using propofol, but really does not matter, and he was harping on that. So they say they kind of go on with the scenario, and the patient is intubated, and here they say that the blood pressure drops to 50/30, just very low. Scott Weingart asked the guest speaker, the anesthesiologist, what would you do if you didn't have blood? Because I guess the hospital that he comes from, it's just, everything is squared away very well. There's unlimited amounts of blood for these patients right away. So he asked for doctors, and I would imagine kind of everybody that would run into this situation where you don't have blood, what would you do? He said it's really clinical judgment, but he was saying he would give 250 to 500 through a warmer of just your crystalloid, and says he doesn't want to do it, but he's not just going to watch a patient completely bottom out. Again, he goes back to stating that while that is an obscenely low number, and like this patient will die, they're not going to die as quickly as your 80-year-old patient would, but it gets very difficult to get a room of people to kind of stand by while the blood gets there when you could give them fluids now. So he kind of goes into that and talks about just the importance of blood, that I feel like is kind of very justifiably kind of beaten to death nowadays in trauma care, but again, crazy important. So then he kind of goes on and he talks about something that he does with these patients kind of when they're in surgery. And so he was saying he will give a combination of blood and a combination of fentanyl, and he will kind of give these 25 to 50 microgram doses to get more vasodilation, and basically stating the blood pressure will come down because of the fentanyl, and then he'll give more blood, and then that'll kind of raise the pressure. But he was stating he doesn't want these patients at like 110 systolic. He wants to keep them lower to make the surgeon's job easier. And I know we're kind of getting away from EMS now, but just the thought process of it was very fascinating. Kind of doing a balancing act with the fentanyl and with blood, and saying once they've hit about 500 micrograms, all these opioid receptors are just fully taken up. So you won't get a blood pressure drop if you give any more. He gives a huge slug of it, and then he just manages with blood there. I thought that was just kind of rather fascinating, and it kind of made me start thinking about the physiology of it. And it just kind of seemed like it seemed correct when he was talking about it, but then I don't know if my mind started kind of getting twisted in knots, but just seems like, why would you want them to vasodilate? Because even if you're giving more blood, I would imagine these blood vessels are now bigger. Won't it cause it to bleed more? Then also on that same kind of the opposite spectrum, if they are vasoconstricted, eventually they're going to run out of that kind of cholamine. So I'm wondering if he was doing it because of that, because now you're not so much relying on the catecholamines to keep your sympathetic drive up, and rather he's just returning them to a normal tone, vascular tone, and getting proper fluid in there.
Hmm. I'll have to think on this more and either read this or take a listen to it. But I guess potentially the idea is that if you're in a shock state and your body is trying to maintain perfusion to things that are vital, so it's going to clamp down at the periphery, things that are considered non-essential, I guess, and like shunt blood to the organs and to the brain. So maybe the idea that he's referring to is if you're blunting that process a little bit by giving fentanyl, you maintain perfusion peripherally. So you're like avoiding a buildup of lactic acid and any like metabolic byproducts. And then if you do it too much and the blood pressure goes down, then you give a little bit of blood. But that I'm not entirely sure about. Like as a thought experiment, I think it sort of makes sense, but I might have to think on that one a little bit more. But yeah, I guess I'm not familiar with that strategy of titrating small fentanyl bumps with transfusion. But I also don't work in that setting. Like I don't work in like in the OR. So yeah, I'd have to think on that a little bit more. But one thing that you mentioned that we kind of skipped over and moved on to the next part was about the fluids in like things you mentioned, like if you were managing this patient somewhere where you don't have blood products, like other things you can do, like to avoid cardiovascular collapse, like while you're waiting for blood. So I think that like giving small amounts of fluid is like, it's not ideal, but it's okay. If we are going to give fluids, we for sure want to keep them warm. So if you're in a facility, you have some kind of warmer. Some transport services do have warmers that they use. Like in the field, if you got nothing, I guess you could like just on the distal end of your IV tubing, just put all your hot packs there and let it, just like make a tunnel of hot packs so that the blood passes through. That works like sort of okay. Like it'll get, like if you're in an outdoor setting in the wintertime, it'll get fluid. Like if you've ever, I don't know, probably haven't done this, but if you've ever had like a bag of IV fluids when it's cold outside, it's freezing. Like you'll be like chilled out instantly. And using hot packs will like get it from freezing cold to like tolerable, but it's still uncomfortable. So I'm not sure that just using hot packs is like an ideal strategy, but it's better than nothing. So and obviously like it probably is a function of like how many you have and how well you like, the more surface area of that hot pack on the tubing, like the more it'll get warm. So yeah, I guess if you didn't have blood, things you could do is like just make sure you can do whatever you can to keep your patient warm. So like warm your IV fluids if you're giving IV fluids, put blankets on them, turn the heat up in the back of the truck or in the trauma bay or the OR, wherever you are. And then in this situation, the patient is probably intubated because we already talked about like our RSI medications. So one of the things in that, like we used to refer to it as a trauma triad of death. Now we're tending to call it like the lethal diamond. One of the components there would be acidosis. So we can potentially like mitigate that a little bit by ventilating our patient to a goal that's higher than normal. As far as like how to measure that goal, like what specific quantitative value we're looking for, that data really hasn't like flushed out yet. But basically, the simple way to do this is whatever your baseline end tidal CO2 is, you don't want it to go higher. You want to keep it there or lower. It's totally okay to like have a patient who's like we're ventilating them until their end tidal is like down into the 20s. The caveat there is that if they're like in a low perfusion state, their end tidal is also going to be low. So it's kind of hard to measure. But basically, like if you had them on a ventilator, you can just aim for a minute volume or a minute ventilation goal that's like higher than what's normal. So we would say that this might be a little like too far into the weeds on this, but we'd say like for the average patient, our normal minute volume goal is 100 mils per kilo per minute. And then somewhere in the area of like twice that is probably okay for someone who's markedly acidotic or who wants to prevent them from getting markedly acidotic. Now that double number is like, I don't know of any data that like fully supports that. So anywhere like between the normal 100 and like the double of 200, like somewhere in that range is better than nothing. But basically, we don't want them to get more acidotic. We use the ventilator as a machine to like prevent that from happening and
Yeah.
like ideally correct it. But like in the acute setting, like we're not going to fix it fast, but just prevent it from getting worse.
Mhm.
So yeah. And then the last thing, like if we don't have blood, most places have access to TXA now. So that's another thing we can do.
Stop that bleeding.
Yeah. So yeah, I mean, standard bleeding control, obviously, and then TXA, keep the patient warm and do whatever you can to prevent acidosis. The calcium part of this diamond is mostly discussed in the context of giving blood products. There may be an argument, and I don't actually know enough about this particular point, of giving calcium in general just to facilitate the clotting cascade. And we talked about last time about increasing like cardiac function, cardiac contractility by giving calcium if your calcium's low. I don't know what like if you were just to take like a random sample of calcium levels of people coming into the hospital in like traumatic injury, like what percentage of them are low of normal. But like maybe we give calcium even in the absence of giving blood products just to help with that part of it. That I don't know about. I'll see if I can find something to either support or refute that. But yeah, those are all the things you could do like while we're waiting for blood to show up, I guess.
Yeah. And it sounds like a lot of that would be good to do, because how many ambulance services realistically have blood? It sounds like that would be really good stuff to do on the way to the hospital. So
yeah, and all of those things are things we can do in the ambulance. Yep. Yeah, and hopefully we'll see more ground EMS programs carrying blood in the future. But yeah, we'll get there someday.
It's funny that you brought up calcium, because the second thing I typed up, the second podcast, is exactly over that, the hypocalcemia with hemorrhage, and you covered.
And these are both these are both MCRIT podcasts.
Yes, sir.
What are the numbers? So I can look them up after.
Or you
can send it to me later. That's fine.
Yeah. So I went to the archives. I'll pull them up for you. But yeah, the Richard Dudden one is a MCRIT podcast, 30 minutes, and then this one that we're about to discuss was a 20-minute one. So just like you were saying, they added the hypocalcemia to the what used to be the deadly triad, making it a diamond now. So they were talking about blood products just in general, and saying how there's citrate in them to keep the blood from clotting in and of itself, just when it's in the bag. But saying that the citrate will result in a lack of calcium. It will drop the calcium. They're already having a hypocalcemia problem from directly bleeding it out on whatever surface. So they were saying they like to give calcium. Now, I don't really remember where these two people work, but one of them was like a special forces medic, and now he was in med school. And then I believe another one was a doctor actively. So one of the guys has really good information on kind of how the military does things, how the military is working to do things. And it sounds like he was on one of the research teams in the military regarding hemorrhagic shock exclusively. So he has a lot of good tidbits in there. But the protocol that he was saying he used, or rather maybe he uses at the time of the recording, he was saying he just pushes 1 gram of the calcium chloride during the first unit of blood. And then from that point, for every 2 units, he was given another gram. He says some people do 4 units, given another gram. But he really just goes into good detail, just basically talking about how this calcium is crucial for the clotting cascade. And Scott, it's kind of funny that you brought up the fact that you can't think of any study that has been, what is the calcium level of these hemorrhagic shock patients? Because he was very stoked about this topic, saying that for years he's kind of done like a little project of his own. He'll go back on these patients that he has and kind of track their calcium, and saying that it was very, very low, but obviously he can't just go around saying, oh, I pulled these labs and try to produce this
Right.
research. So he was pretty stoked about that. It was overall seemed pretty basic, just the information that they were giving out, just making sure we're giving calcium. It really does make a difference. It can make a difference quickly. I liked it a lot. I did not know they were saying hyperkalemia is a common response to trauma. I did not know that. I know if you have a crush injury, the breakdown of that muscle can lead to hyperkalemia, but I did not know that in and of itself, just bleeding itself causes hyperkalemia. And I wonder if it's because you're bleeding calcium out, and don't the two kind of antagonize one another?
This is another thing I'm not entirely sure about, but I think maybe two mechanisms. One would be that in an acidotic state in general, your body, like your cells in your body, become a little more permeable and potassium leaks out. So same thing in like a diabetic ketoacidosis where we're about hyperkalemia. So that's the one mechanism where, like, just because you're in like a low perfusion shock state, you're locally getting acidotic at those cells and they leak potassium in. The other one we did just from tissue damage, like from when not able to talk right now. When a cell is damaged and it breaks, when lysis occurs, you lose potassium like directly there. So it could be either one of those mechanisms. And likely it's some combination of both, but I'll have to look into that specifically to be sure. Or it could be something else that I'm not considering.
Yeah, I mean, it sounds right to me, man. If it sounds good to two people, it's gotta be right.
See, this is problematic. This is where problems come from.
The entirety of Facebook, there's like 20,000 people in groups that are.
Yeah, because you could just look for someone who agrees with you.
Yes, yeah. You know, I wonder if people think that, because nowadays you hear, especially a bit of the older generation, maybe 40s and 50s, and no disrespect to them, but you kind of hear them use Facebook as like a legit argument, you know. And I wonder if they, obviously they know, but I wonder if they give any thought to the fact that, you know, there's almost 400 million people in America alone. You're bound to have a political subject where there's tens of thousands of people all agreeing on the same topic.
Yeah, that is problematic. Although I don't have any experience with Facebook, so I can't. Yeah, I've managed to steer clear of that one.
I despise social media, not because like I won't follow people that I don't like seeing their opinion, right? But there's a lot of interesting things that are both kind of informative and just absolute nonsense, and I find myself wasting large amounts of time. All right, so the trial I looked into, before we move on, are we good with trauma?
Yeah, I think so. I don't know if you had any specific questions about the calcium, but it seems like you got your bases covered there. I think I actually have listened to that MCRIT episode. So I'll put a link up here, and also like the research that the guys did. I think it was, I don't remember who it was. I should probably know this off the top of my head. But the papers they did through the military about like investigating this idea of giving potassium with transfusions in the field. So I'll pull up links and send them to you.
Oh yeah, yeah. I'm building a small collection on the things you sent me. So just to kind of summarize with the trauma, just keep them warm. Try not to give them fluids if you don't have to. Give your TXA, give your calcium, get up and get gone for the field ambulances.
Yep.
Kind of the same suite. With that, I think that is good on the, you know, let me ask about it now because I have it written down, but really just kind of fits in. So with your head traumas, I know that the overall CO2 plays a big, big factor. And I believe if the CO2 is high, they get the increased intracranial pressure, correct? And if it's really low, they get the cerebral vasoconstriction.
Yeah.
Okay.
Think about that. So if they're hypoventilating and their end tidal gets high, that can cause an increase in ICP. But then again, if we like hyperventilate them super low, then that's also problematic. So yeah, we generally aim for a goal just like low of normal. If we're like ventilating somebody, like our normal goal would be like 35 to 45, and we'll like do on the lower end of normal, or like maybe down to 30 to 35.
Okay. And my second question on that. So, and I forget where I read this, and I don't know how common this is in head injury patients. I've maybe had 3 pretty bad blunt trauma head patients. But just is there, or have you been in a situation where you can't, with a normal respiratory rate, you can't keep that end tidal where you want it, and it just seems like it's jacking through the roof? And if so, what do you think about brief hyperventilation to do that? Or I would imagine that would cause problems in and of itself with just stacking all that pressure in the chest.
Yeah, I guess I've never ran into that issue. Like we sometimes have a tough time maintaining like our ventilation, like with our end tidal being super high if we have like some kind of like chronic lung disease. But generally, like aside from that subpopulation, like it's pretty easy to like ventilate people down, like to hyperventilate or to ventilate more than whatever our normal minute volume would be to get their end tidal to go down. We more often run into the opposite problem where a patient is breathing way faster than we would want, which is a little bit safer for us, like as far as managing the vent. So we more commonly see a situation where the patient is like breathing too much and our end tidal is low of goal. We don't often see it outside of that subpopulation with chronic lung disease where we have a high end tidal CO2 that we can't bring down.
Well,
So
that's
yeah,
good.
yeah. So I guess I've never been in that particular situation. Yeah, it seems like not impossible, but like unlikely to happen.
Yeah. Yeah.
Especially once you're like managing, like if you've intubated them and you're managing the airway manually, then like it would be a different case. Let's say if you had a patient spontaneously breathing and you had like a side stream cannula on them and you're monitoring it that way. But then if you saw like in that situation, if you saw that they like weren't moving enough volume, like their minute volume was low, and that was indicated by a high end tidal CO2, that would be an indication that maybe you need to more aggressively manage the airway, like start PV ventilations or work towards RSI or something like that.
Mm-hmm. It seems like RSI really, once you kind of give that paralytic, it seems like it removes a lot of these kind of situations at hand, because now you just have full control.
Yeah, I mean, it seems like the ideal situation because you just take everything away and then like you're in charge.
Yeah.
But then it's all on you to like know what to do. So it's potentially problematic as well.
Were you nervous the first time you RSI'd somebody?
Oh yeah, for sure.
Yeah.
Yeah.
They don't give us RSI where I work, and I would like to RSI people, but yeah, I would imagine it would be a very nerve-wracking thing.
Yeah, I mean, it's definitely an interesting like skill to go from like working on an ambulance where you don't have access to that, and then like it being like in your scope and you could potentially do it on any shift. Yeah, like I mean, I still get like, you know, when I do have to RSI, like I'm not like a superstar. It's not like I don't get nervous and like my heart doesn't go faster. But we have like systems for like how to manage that effectively. Like I religiously use a checklist. Like I, you know, whenever I'm, not every time, but like often when I'm at a base that has like an airway head sitting around, like I'll just get out and play with it. Like I'll practice my bougie techniques and just like do a couple like manipulations of the airway. Like, I don't know. Like I think that if I didn't do those things, I would probably feel a lot more nervous whenever it came up. But
yeah,
I don't know. It's like one of the things that like I know that it's like it could potentially be stressful. So like whatever I can do ahead of time to mitigate that, then yeah, that has helped a lot for me. And some people just wing it and they're just good at it, and they just like
yeah,
there are like many medics out there who do RSI and like never use a checklist, don't really do things the same way every time, and like they've never failed.
Mm-hmm.
So but like I don't think we should bank on that, right? Like I think we should have systems for those kind of things.
Yes, very much so.
Yeah.
Sweet. That cuts that out. And that is the last of my trauma. Everything else is a medical. Yes.
All right, let's hear it.
You want to finish the questions now, or you want to move on to the MI trial? It is your choice.
Let's talk about you said you had some oxygen stuff to talk about.
Yeah, that's what this trial is.
All right, yeah, let's do that.
So essentially, this group went and gathered about 6,600 patients over the course of, I think, 4 or 5 years. And this is in Sweden. They had somewhat strict criteria. You had to be sat in at 90% on room air. You had to be 30 years or older. You had to have had symptoms, your classic kind of cardinal symptoms, chest pain or short of breath, less than 6 hours. You had to have either elevated troponins or EKGs, and that was pretty much it. So what they wanted to find out was, does oxygen actually help in your patient that is not hypoxic on room air with basically heart attacks is what they wanted. And they ended up getting 75% of their patients ended up with the final diagnosis of either non-STEMI or STEMI. So with this, their methods were, they used 6 liters per minute for anywhere in between 6 to 12 hours. The median ended up being 11 and a half hours. They did it through an open face mask. Now, I don't know if that is like a non-rebreather. I don't know if that's more of a Swedish thing or all we have is non-rebreathers. I guess the open face mask we have is we'll do like neb treatments through it. But
yeah, it's kind of like the non-rebreather mask, but no reservoir and just oxygen into the mask.
Oh, okay.
And then it doesn't have like the flaps on it. It's got holes in it. So it's kind of like doing blow by, but for a grown up, essentially.
So they took their 2 control groups. One was just the ambient air, and the other one was receiving the oxygen through the 6 liters, 6 to 12 hours. So they kind of looked at 3 things. What was their final oxygen what was their final oxygen on room air at the end of treatment? What was the 1-year mortality? And what was the readmission rate on these 2 groups? So with the final oxygen or saturation, 99% was the oxygen group, 97% was the ambient air group. For the 1-year mortality, it was a 0.1 difference, 5% for the oxygen group, 5.1% for the ambient group. Readmission rates within 1 year, the oxygen group was at 3.8%, and the ambient air group was at 3.3%. The mortality was any cause of death, though. There was no repeat heart attacks. It was just basic 1 year mortality. They kind of go on to discuss a little bit further how they did it. Again, they included like the final diagnosis of it. They went into more detail on the inclusion criteria. The really only real exclusion criteria was if you went into cardiac arrest with EMS or you arrested at the hospital, because they're going to put you way past 6 liters per minute, just managing your airway. I liked it a lot because their evidence with the 6,600 patients, and from what I could find, this was the largest trial at the time with the 6,600 people, 3,300 in each group, just showing that there is no difference in the outcomes of at least their patients who were not hypoxic. Now, granted, he talked about a lower mortality rate with theirs being 5%. I think the average in Sweden was 14%. They explain that by just saying a large chunk of the people that die will be hypoxic, so they can't be included in the criteria. So this was solely on if you're oxygenating enough on your own. He did mention 2 other trials. Now, I have not looked into these trials, so I don't want to go and speak ill of them at all. He talks about one is the AVOID trial. It's an acronym just like this detox trial is. They reported larger infarcts in STEMI. Now, this was only STEMI patients in theirs that were receiving the O2. And then the Cochrane report in the 2016 update was saying that there's no evidence of it. They were talking as if this is kind of a something that is seen with these new studies coming out and saying, but again, they did not show, this study did not show any harm in it. So I was kind of wondering your thoughts on that. I personally, if I have a MI patient, if they're not short of breath and they're satting fine, I don't put them on oxygen. I went and found this because I've got crew members, and they're great at what they do, but that's what they know, and we'll show up to a house, and you get busy, and sometimes the fire truck gets there before you. Maybe you're racing back from a hospital. And I've had a situation where the patient was fine, everything was fine, but it looked like a non-STEMI, and they had him on 4 liters. I turned it off, and I find myself often having to unplug. It just seems like in EMS, it's very common to just kind of blanket oxygen people.
Yeah, I mean, that was how I was taught when I first, I guess I did my CPR class and first responder stuff through a fire department. And that was the rules. Like, everyone gets oxygen because it makes it look like you're caring for the patient, and probably doesn't hurt, right? And to be honest, I think that in the last couple of years, there's a lot of discussion about the damage that oxygen can cause. But I think in most situations, particularly in EMS, it probably doesn't impact outcomes, as explained in this paper. So if you're in a hospital setting and there's, you're leaving somebody on the 6 liters for days and days and days, it's probably different. But for in the study, 11 hours, in our setting, less than an hour, it probably doesn't matter. So in your situation, you have somebody with a complaining of chest pain and somebody else puts them on oxygen, it's probably not worth ruffling feathers to be oh, let's take that off, right? It's probably worth it to just leave it. And then when you get in the truck and you're by yourself, then you can turn it off. It's not going to hurt anything acutely. So yeah, I guess that's kind of how I feel about that. I think that this comes up a lot. I actually just recently saw a post. I have to look and see who it was. But there's this phenomenon in the lungs called hypoxic pulmonary vasoconstriction.
Yes.
So basically the way it works is if your blood vessels in your lungs get hypoxic, they constrict down, which is the opposite of what happens peripherally in your body. So in my arm, if my arm is hypoxic, those blood vessels dilate to get more oxygen there, right? But in the lungs, there's an opposite reaction. And the idea there is that it prevents blood flow from being wasted. So if I have a region of the lung that's not getting oxygen, I shunt blood away from that region so that I can keep the blood going to places that are getting oxygenated, right? On the flip side, there was a post recently that somebody put up about the idea that if you give too much oxygen to somebody, this mechanism could cause worse outcomes. So if you, I'm trying to think through the sequence here. So if you had somebody who had poor perfusion to a part, and then the alveoli were didn't have a lot of oxygen in them, and the perfusion was poor, but you give more oxygen and then it causes vasodilation, you could cause a shunt where you're wasting blood flow, which, talking through the steps of that sort of makes sense, but I don't think that actually happens to a degree that would have a clinical impact in real life, because that doesn't always happen super fast. It's not an automatic on and off thing. That's something that I reached out to whoever it was that posted and be hey, let's talk about this. I'm curious to know where this came from. I haven't heard back from them yet, but I would be interested to explore that idea a little bit more. Basically, in the greater context of I think that it's worth limiting oxygen to when it's actually indicated. But I do think that there is a movement to finding everything wrong with oxygen that is potentially problematic, because then you have cases where people do need oxygen and don't get it, whereas the damage caused by giving oxygen is quite limited. potentially even like negligible in the EMS setting. I say potentially because like I think there probably are cases where like we probably shouldn't give it and it could cause damage, but like I don't think that those situations are that frequent in the EMS or even in the critical care transport setting.
Yes.
I think it's more of like a long-term situation. So,
Yeah. And I like I like that you stated that it is that long term, because the original reason that I wanted to look into this was I just wanted to be sure that there wasn't something out there, saying we're just doing devastating effects to people. And oh, I found this out, like, oh
yeah, and
hell, no, I'm kind of incompetent.
yeah, I don't know if this is where the whole idea started, but there back in the day with like babies, we used to like leave them on high flow oxygen for a long period of time, for like days or weeks maybe.
Oh wow.
And come to find out that that can cause like I don't know specifically, it caused problem with the eyes, like the eyes don't develop quite like they should. So you had like kids growing up with like poor vision, and they kind of like worked backwards and figured out that like, oh, maybe we shouldn't be giving these babies oxygen for a long period of time.
Yeah.
And the culprit there is these like free radicals, right? Which I honestly like would have to like consult the textbook to figure out like all the specific details of
I'm
that.
glad you said that, man, because I was like, I don't know what the hell a free radical is.
Yeah, but that narrative, like oxygen is bad because it like hurt these babies' eyes, has like carried over and kind of like snowballed into this effect where like everyone's like anti-oxygen, other than the guys who like and gals who like just grew up in like the first responder community where we put oxygen on anyone, right? So there's like that mentality still exists, and then there's like a new mentality where like, oh, oxygen's bad, don't give it to anyone. But like we live in the middle, and in our setting where we're like acutely managing patients, like it probably doesn't matter that much.
Yeah.
But yeah, I guess in summary, like if your patient's hypoxic based on like a pulse ox, give them oxygen. If they're not, like we don't need to, but if somebody did and you want to save face and like not ruffle feathers, it's probably okay. And then if it's like appropriate for you to do it when they're like out of eye shot or whatever, then you can make your own decision. But I don't know if it's worth like putting your foot down on a scene like that to be like, oh, like oxygen dangerous.
Yes.
Yeah.
I've never had to do anything of putting my foot down. And I really hope I don't, because I work with the same people every day. It's the same shift, same crew, and they're all they basically raised me,
Right.
Still raising me. So I definitely don't want to go and be pissing them off. We talk enough trash to where everybody's pissed off once a shift anyway. I don't need something serious to get them upset by.
Yeah, and this like brings up something that's like sort of related. Like if there's ever like in that situation where you're like a relatively new guy in this setting where people are doing things that like don't align with practice, but like the culture allows for like joking and hazing and that kind of thing, like you can always like address that in a joking way. Like, I don't know, like make a joke about like, oh, I didn't know what to do, so I put oxygen on them. Ha ha ha. Right. Like you can address it in a way that's not like confrontational. Like I make the joke with like some of the people I work with who like are resistant to using bougies. Like if I set you up for an airway, I'm just going to take the stylet out and throw it in the trash and like set you a bougie. Right. Like you don't have to like, you like do it like.
Yeah. Lighthearted.
Yeah. So I don't know. It's like just a potential thought I had there.
I like it, man. As far as those are kind of my three things that I wanted to discuss. I do feel much better and again, this trial has a median duration of 11 and a half hours of oxygen delivery. So what are the odds that even an hour transport, if I'm going from the sticks to like a city hospital, that's an hour. So what are the odds that it's really doing any harm whatsoever?
Right. Yeah. I thought of another example that sort of explains this. There's this concept of like absorption atelectasis. You heard of that? It's like the idea is that in your alveoli, you have oxygen and mostly nitrogen. So like at baseline, you have like 21% oxygen and whatever the rest is, like 79%, 78%, then like there's 1% of random stuff. So like if this is your alveoli and you have like just 21% like getting absorbed in the bloodstream, like it like shrinks a little bit, right? But if you like do a oxygen washout and fill the whole thing up with oxygen, when the oxygen like goes into the bloodstream, like pew, that alveoli collapses. This is the theory. So the argument is that like don't do like a a nitrogen washout. Like, don't just give 100% oxygen till all that nitrogen is gone. Because if your
Oh.
patient's super hypoxic, then like you're going to collapse their alveoli. But that said, like, this is another one of those cases where like I don't think that the data fully supports that. This is like kind of up in the air.
Yeah.
But it's not just that the alveoli is being held open by like forces like pushing it open like air in a balloon. Like there are like external things like around the surface of the alveoli holding it open. Like, like you have surface tension of fluid on the outside of it that's like helping it maintain its state. And like,
Is that the surfactant?
yeah. So yeah, I'm not convinced that that actually happens, but I don't know. It's just like another interesting thought about the I don't know, the oxygen haters out there.
It's fun, man, isn't it?
Yeah.
And just one last piece on that. So like your surfactant kind of keeps it from collapsing, correct? There's multiple things to it, but that's one of the bigger biological factors of it.
Yeah.
And then your elastin helps it actually, like the alveoli exhale in and of themselves, right? Because your COPD or emphysema itself, it traps air because it destroys that elastin.
Yeah, so the elastin, this is again something I should probably reference in the textbook before I talk about, but if I recall right, the elastin is what's like pulling it back, like that's causing it to recoil, whereas the surfactant is like holding it open. So yeah, that I guess makes sense. Like if the elastin is broken down, then you get like that hyperinflation.
Yeah.
So that's why like you have these external forces that are like managing to some effect the shape of that alveoli. It's not just the pressure of the air inside of it. That's why I'm not 100% convinced that like the absorption atelectasis thing is valid, but it likely is somewhere in the middle, right? Like maybe it has like some effect. I mean, I think that's probably the case for like most of these like niche details we're trying to work out. Like oxygen isn't bad, but it does have like some therapeutic value. Like we should never give it, and we shouldn't always give it. Like, we should give it sometimes. Just everything in moderation.
I like the things in the middle, just doing things because they've always been done is just an absolutely terrible reason to be doing anything, medical or not.
Yeah, that's true.
So if you're good with it, I've just got a couple more questions for you.
Yep, let's hear them.
So I know we've been talking about ketamine a lot. I feel like you've told me this, but usually I'm typing notes, so I'm not doing that this time because I feel like sometimes I miss one or two things. Let's say you're going to give an actual bolus, right? I know we talked about the 0.25 milligrams per kilo over 10 for pain. But if you're going to give this for, let's just say you've intubated somebody or just any procedural sedation is what we have it for. What, if you're pushing 1 milligram per kilo, I know you're not going to slam it, right? Because it seems like a bad idea. But what timing kind of would you, and I know nobody's actually sitting there with a stopwatch on their iPhone, looking at it. None of us do. But would you do it kind of slower than you would like other medications or?
Yeah, I mean, I don't often like give medications where I just like slam it. A lot of times we just have like an IV bag hanging because it like makes it easier to get to, like, you can put your medications in a port. So like if I were going to give a bolus dose of ketamine, like if I just have like a couple of drips going, like I would just put it in the line, and you can slam it in the line. Like it's not like it's going to make it all the way in the patient right away, and just let it drip in. And that's how I do like most of my pushes. If I am giving it as a push, like I just give it, I don't know, slowly, like, I don't know, like I grab the syringe, I hook it up, and then I don't know, like slow. And then I do the same thing with a flush, just slowly behind it. Yeah, I mean, I think like if you're giving a big dose of ketamine and your patient's like alert, like there is, you could potentially cause like transient like apnea, hyperventilation or something like that. But like in our cases, when we're giving big doses, like the patient's already intubated. So it's not really so much of a worry for us. Yeah, I think it's more of an issue like in the like procedural sedation side of things. Like let's say you're in the ER and you like broke your arm and they're trying to set it. In that situation, like working in the ER setting. I'm in an ER in a couple of years, but like then I would be a little more diligent about like giving it super slowly. And especially like when my patients, like it's easier to do that kind of stuff. Like you're talking to a patient, you're like, all right, I'm going to give this and we're going to give it over like 30 seconds. And like you're just sitting there with them hanging out, like it's easier. Whereas like for us, like, yeah, like it's not so relevant in our setting.
Yes.
Yeah.
Yes, I like it. I gave ketamine for the first time right before I got COVID. We ran a code and the lady legit like started like as soon as I intubated her in title, she had to have gone from a PEA that's not a real PEA to now she's contracting enough for her pulse. But she was we had like maybe 5 minutes left, too much time for you to just be flailing your hands kind of about. And
Yeah.
it wasn't like, it wasn't coordinated by any means. It's just kind of flailing and stopped and flailing. So I gave the one and I just pushed it like a normal. So I'm glad that you said that.
Yeah. Yeah. And in that case, like if your patient's intubated, like, I mean, like we don't necessarily, like we never really need to like actually like slam medications other than adenosine. But like as long as you're giving it like, I don't know, somewhat reasonably. Yeah, that's the official
Dude,
word. Somewhat reasonably.
Yeah, I like it. Dude, I had this patient, just your frequent flyers, like call you at 2 a.m. type. And I took him to just the normal ER. It wasn't like our local one or anything, but it was in the city. And I had a nurse that was like, I told her, always saying this hurts, he's in pain. I didn't give him any narcs. And she's like, I'm gonna slam Benadryl on him. And I was like, whoa.
Yeah. Nurse Ratchet, man.
Yeah, dude. I was like, what's going on here? Let me get away from you, for my license is going as well. So Rebel, I saw Rebel EM. It was an Instagram post, and he was talking about glucagon for the airway, the smooth muscle relaxant, and he was just saying it really doesn't work, was kind of his thing. And I'm sure I'm strongly summarizing what he said. But then, so I asked him about magnesium because I had also heard about magnesium, especially from some like older medics. Mm-hmm. And one of them in particular, I love the guy to death. I mean, I respect him like his family, but he told me a story about he gave a patient magnesium for like relaxing the airway, and just an old man, choking on a steak. And he said that by the time he got there, it worked. Now, granted, who's really going to know if magnesium was it or if he just actually passed it down finally? But I just thought it was interesting how he was kind of, and I would assume the guy posting for Rebel EM is rather bright. So you agree none of them really work that well for the smooth muscle and the airway?
Yeah, I don't know of anyone personally who's ever like had any success or even ever tried like giving glucagon. But that used to be something we would teach in medic programs, that like if you have someone choking, to give glucagon. Mm-hmm. But a lot of places don't even carry glucagon anymore because it's kind of expensive and like hard to get.
Yeah.
Yeah. And like if you have someone choking, you're not going to take the time to like reconstitute a medication to get there. Like you're going to be doing other things. And then like with the magnesium, like we generally don't want to give that fast. So you're not going to like set it up to infuse over 10 minutes and like hope they're like still choking 10 minutes later. Like that seems a little problematic.
Very much so.
So yeah, like I guess I haven't put a lot of thought into that one in a very long time, but I wouldn't mess with like giving drugs to try and get like smooth muscle relaxation, somebody choking.
Yeah. It just never really seemed like a good idea, especially with mag. I mean, pretty much every use of it is slow, real slow. Yeah. You answered the hyperventilation one with that. And then, how they say, and I guess it's more than just they say, but with pediatric cardiac arrest, it's the airway and the respirations are the problem a huge majority of the time.
Right.
Would you, would you tube them right away? We're not skipping any of the vital stuff that we do, right? Like let's say they're in full cardiac arrest, you're still putting them on the monitor, you're still doing compressions, you're still getting a line or an IO, but would you make it a point to tube them a lot quicker because
not necessarily. Like I think still, I mean, really depends on like how many hands you have on scene. Like
Mhm.
once you have free hands to manage the airway, like that's the appropriate time. Like if it's just like you and your partner, like it's probably not going to be the appropriate time until someone else shows up. But like if you're rolling up with like 6 humans, like
Mhm.
you might as well be sooner. But like I don't think I would skip other things to prioritize that,
Mhm.
because you are ventilating the patient, um, with a BVM. Just focus on like doing like good ventilations, like
Mhm.
actually like getting that airway open and make sure you have a seal and ventilating the patient like per your like resuscitation protocol.
Mhm.
So yeah, I wouldn't switch everything up to try and do that sooner.
Sweet. I
Yeah.
would imagine that is a stressful enough situation to be purposely putting yourself out of like the groove that you have for a code.
Yeah. And I think that that's like a really important point is that I've noticed like when I've like made mistakes, it's because I like deviate from what is normal.
Mhm.
Either because like, I don't know, like something catches me off guard and like I go down a rabbit hole, or like I just was lazy and not prepared. Um, a very good example of this is like I've always been like super religious about like when I go on scene, like always taking my stuff in with me and like getting my bags. Like it probably drives my partners crazy at work sometimes. They're like, no, this is just like a basically a BLS transfer. Like, well, we're still going to carry everything in because
Yes.
what if something happens? Like, what if? But I ran a call once for like somebody having a seizure, and like I walked in the room, like in the patient's home, there was somebody at the door waving me in, and I walked in without waiting for my partner. Like we'd always like carry our stuff in together, and
Mhm.
the guy was no longer having a seizure, but he was up and like ready to fight. And like I'm like a scrawny white dude, like working on the truck in Pittsburgh, like almost got my ass kicked because like I was like excited about this seizure call, like oh, like maybe I could do something cool, and I left my partner outside, and like it was me against this like dude who was probably gonna win that fight. So yeah, and same thing with like airway management stuff. Like now I've kind of kicked the idea of like being too cool for checklists, so I don't really have to worry about that. But like that is a very common problem, I think, or used to be a problem for me, and like generally in EMS is that we like have a sense of confidence in our ability to do those things. We think we don't need help. Same thing applies to the bougie. Like nobody wants to use the bougie because they already know how to intubate. Um, but yeah, anytime you deviate from your routine, like you introduce the possibility of like more problems. So if you're used to running a code specifically with adults, when you have a kid, do the exact same thing and just change your doses and your ratio, I guess,
Yes.
is the point I was trying to make. Like don't think you need to switch it up. Uh,
Yeah,
yeah.
I like it because I'll be damned if I run a bad code and it's a kid. Like I feel like if I work in the business long enough, just statistically, it's going to happen.
Yeah.
But let's do everything. Kind of like what you were saying earlier about practicing your innovations and the things that are high intensity but low frequency. And just
Yeah.
doing everything you can to be prepared for it.
Yeah. Yeah. Another thing, like along those lines is I don't know if you've checked out the podcast, but I'll send you a link. I did an episode, I only have like a few podcasts out, like I don't do it that often, but I recorded an episode like a year or so ago with a buddy of mine, and he had just started a job with a new flight program, and he was trying to like learn his new protocols. So he basically like recorded himself like speaking through his algorithms, and he just did it from memory until he like had them all memorized, and then like now he has them recorded on his phone, so like when he's driving to work or whatever, he can like listen to them and
Oh,
just brush
yeah.
up. And I did the same thing for like my RSI procedure where I work, so it's just like a step by step of like how ideally I would want that scenario to go, and I just have it as a recording on my phone. So like I work like all my shifts in like 2 week chunks. I work for 2 weeks and I have 2 weeks off. So when I'm going back to work, like I have this like process for like getting back in the mood for going to work. And that's one of my things. Like, when I'm like commuting to wherever I'm going, I like listen to this once or twice. Be like, okay, like cool. Like, yeah, just like a way to like,
Yeah.
there's a lot of like data out there about like visualizing performance as a way to practice when you like don't have access to the things. But I find it pretty tough to like just like close my eyes and think about it. Like that doesn't work for me. But like having a audio script playing in my mind like is enough of an anchor to like visualizing that it works for me. I don't know if it works for everyone, but I don't know. I'll send you a link. It's worth like thinking about, like if there's, like if you wanted to like do something like that for working a pediatric code.
Yeah.
um I think that's like a reasonable thing to practice.
Yeah, absolutely. Well, I had talked to a doctor one time and asked him any advice for just going into further school. And he said that he did that, maybe not for situations, but just in general. Whatever tidbit, whatever exam he had going on, he would record it on, I think, I mean, he's so old, man. He probably had like the actual recorders. But he would say at any time he was sitting somewhere, he just had a little headphone jack and he'd plug it up. He's eating lunch, he's listening to it. Maybe he's driving somewhere, he's listening to it. He's waiting, he's listening to it. And he really spoke highly of it because he says he liked that it was his own voice and he didn't know any research or anything. Maybe I didn't ask, but he said the fact that you remember looking at information, you remember speaking it, and now when you're listening to it, you're going through that in your mind again, kind of like, oh, this was happening when I was saying this.
Yeah, I think like I anecdotally had the same experience. Like I listen to like a fuck ton of podcasts like all the time. Like I spend, like every time I'm working out or have like time in between things, like I'm in my car, like hours and hours and hours of content. But it's so much like I don't really absorb it all. But like when I've taken the time to record something and like listen to it myself, like one, I can't stand the sound of my own voice, but two, I'm like, oh, like this is me and I took the time to make it. Like it seems to sink in a little more. So I think there is value in doing the work to create that. Same thing with like making note cards. Like you're studying for, like, let's say you're studying for your national registry. You can buy note cards pre-made like off of eBay or off of Amazon or wherever you buy note cards these days. I don't know. But if you take the time to make them, like you probably get more value out of it studying them. So I think there is value in like creating those things yourself, versus just whatever else is out there. Plus you can like dial it into like the specific things you need to know.
Yes.
Because anytime you have like, if you're listening to a podcast, like maybe it's a really good podcast, but there's always like portions of it that don't apply to what you want to know or to what your clinical setting is. So you kind of have to sift through it. Whereas if you're making something, it's like 100% relative.
Yes.
100% relevant, not relative. That'd be weird. Yeah.
I'm a huge fan. I got this freaking binder. I've been working on this thing for quite some time. It's just in that, you remember medical school when you're kind of done learning things and you're just kind of doing your clinical rotations, like you're not done learning, but they're not forcing info down your throat anymore. I started making it then and it outgrew one binder, but I'm just a huge fan. Even if it's typing, I'll have to go through it and highlight, but I like that. I just like the redundancy of it, to where by time you're just purely reviewing it without writing on it, maybe it's your third or fourth or fifth time having that information. And exactly what you were saying, how you can kind of tailor make your notes, because so many things out there, like let's say you go online and, like the Internet Book of Critical Care, right? Great website, very user-friendly, but there's a lot of stuff on there. It's a lot of stuff to look at, a lot of stuff if you just want that one point, so I really like to type it up. If I had all the time in the world, I'd just write it by hand because I rather enjoy doing things by hand, but that's just not feasible in this world.
Yeah, our time is limited.
Very limited, man. Well, Brian, that's everything I got for you this time.